Thank you for having me here today, particularly for Aura and OIS. So I'm going to talk a little bit to follow what Amida said in terms of where we are now, and particularly the pandemic that's really hitting our dry eyes. Okay, so let's start to think about where we're up to. As usual, my disclosures, so I'm a clinical researcher. I work with a range of companies on research, and also I have some spin-out companies specifically to do with dry eye disease, because I think it's just so important that we translate that research into benefits for our patients. And some of what Amida said about generating that sort of community is really important with our dry eye patients. But actually, the first thing I'm going to do is sit down, because we really need to make sure, as Stuart said right at the beginning, that our focus is on our patients.
Okay, so my name's Ruth Machin. I'm, as you can probably guess from the accent, from the UK. My background is I was a doctor. I was a radiologist specifically for 24 years. And unfortunately, my eyes were the demise of my career, unfortunately.
My name is Sarah. I'm 35 years old. I live in New Zealand. I have two children, two daughters, aged 5 and 8. When I was prescribed isotretinoin, Roaccutane, and had a very pronounced reaction to an incredibly low dose of it, like within a few days. The worst dryness I've ever experienced. I couldn't, it affected everything, driving, cooking dinner, everything. And from then on, it's been constant. My life, so nearly 15 years.
I had this intense pain in my left eye and felt like I had grit in it. And I'd lost vision. I lost about half my visual acuity dropped by about 50% in that eye. So I couldn't see and it hurt a lot. And they took a look and they said, yeah, your eyes look a bit dry. Have some drops, off you go. And that unfortunately was the start of it. And they got worse over about 6 months. To the point where I was eventually diagnosed with neuropathic corneal pain as well from the dry eye disease.
So I've tried all sorts of drops, and these have been the consistent ones that help the best. So this is the ointment thing that most people just take at night.
I'm on either a lubricant drop or a serum drop every 45 to 60 minutes throughout the day.
Even in childbirth, I had to get my husband to learn to put them in for me, because in labour, even when I was labouring quite near the end, I still needed someone to put them in, and I couldn't do that anymore.
If you're just a regular member of the public, it can be really hard, really, really hard to find the right treatment, because people just don't know who to listen to. There's so much noise and information out there. It's very difficult. I think part of the problem is there's a misconception about dry eye disease. I think people think it's a minor condition and a mild condition, and the name, I don't think the name does it justice. Dry eyes, just try these drops, it'll be fine. And I don't think people realise it hurts, and it really hurts.
I always have drops with me anywhere. In Christchurch, we had big earthquakes in 2010 and 11, and I've had a horror ever since of being stuck away from my eye drops and not able to have my eyes open, and even worse. So that's one level of vulnerability, but that just shows you how much of a priority it is.
Please invent a really good product that replaces all 3 parts of the tear film, ideally. So a drop that's this is like, feels like I'm asking for the moon. A drop that's the most like normal tears as you can get, and doesn't have a job lot of extra chemicals that irritate our eyes in it, would be very nice.
I remember being 21, 22, lying on the couch with my eyes shut, listening to audiobooks for hours every day, feeling like life was passing me by and grieving it and just so depressed. Hope has come and change has come from unexpected places, and there are people who are committed to helping and more is being known and learned about this every day. So don't give up hope. What works for one person may not help for you, but that doesn't mean there's nothing out there.
Anything that impacts your eyes has a huge impact on everything you do. And obviously, if you don't look after them and they hurt, being in chronic pain has a big influence on how people live their lives and their mental health as well.
So a huge thank you there to Sarah and Ruth for that really honest reflection, and we'll come back to them at the end. But I remember listening to Sarah 10 years ago saying that she was actually deciding not to become a mother at that stage because she just didn't know how she could cope. So that's the sort of impact that it has on people. So you'll have seen on my disclosure slide, I'm still in clinic, I'm still seeing patients, because that's what drives my desire to make sure that we have the products that we need for the future. So when we call this a pandemic, I think that is totally fair. This is global, and the prevalence is really high. And if we think about the pandemic that we've just had and how disruptive that was to all of our lives, that's essentially what's happening to our patients. So it's really, really impactful on those people. So that disruption to people's lives is really real. So who does it affect? Normally, I'll go back, I'm on the executive of the Tear Film and Ocular Surface Society, and one of the things that they do is they put together these global consensus reports drawing on the evidence. So if we look at prevalence, so how common this is, so this is from TFOS Juice 2, the Dry Eye Workshop 2, a little while ago now, back in 2017, and we've got people like Victor Perez here in the audience who's leading TFOS Juice 3, so we'll have an update soon enough. But here, in terms of the studies, anywhere between about 3.5 and 70%, so yeah, in terms of symptomatic disease, 6 to 54% of the population complain of symptoms. As you'll see in a moment, I suspect that that's higher now. And if we go to the most common definition in terms of these studies, so we can compare between them, you're looking at lots of centers where that's in the sort of high 20s into 30s. So 1 in 3 of the general population having symptoms or a diagnosis of dry eye. But what we did in 2017 is we actually put a much more structured diagnosis together, which is used now in many clinical trials, for example. So we're making sure that they have both symptoms and signs, because that is what the definition says we should have in terms then of our diagnosis. And more standard cutoffs, for example, for our tests to do that evaluation. And so since TFOS Juice 2, we now have a number of studies that have looked with those criteria in terms of what the rate of dry eye is. In the UK and in New Zealand, came out at 30%, so 1 in 3, and that's both with symptoms and signs, not just symptoms. In Spain, 57%, so a huge number, and these are populations, so to match the population of the country. In Asia, they've looked at 8 different studies that have looked at both symptoms and signs, so not the full diagnosis of dry eye, 18%. So again, this is really impactful. These are huge numbers of people involved. But those studies look at people from the age of 18 upwards. What happens if we look at children? So these are 2 studies that I've been involved in, reasonable number of people, so children drawn from the general population, the first one done in central London. And what we found there is that actually if we look at the criteria, so again, symptoms and signs, you're looking at a percentage rate of 18% having dry eye disease. And with each hour of screen time, it increased the odds ratio by 15%. So again, very much associated with this digital lifestyle we've heard about before. The second one was from a gaming convention, slightly wider range of ages. So not all of them were in the childhood age, but 90% of them reported symptoms. 90%. And these are people who are really driving their eyes, concentrating on those screens, not blinking. So huge issues there. Poorer symptomology associated with increased screen use again. Elevated blink rates and reduced proxy of tear film stability. So this is the real worry, not just the dry eye that we've got at the moment, but these children, when we look at their meibomian glands, lots of them have significant loss, even when they don't have symptoms. So what's it going to be like when they're working age, when they're actually reliant on those eyes to give them an income, to be productive? We've got a real issue that we are storing up, a real time bomb there. And so this is a recent review paper put together by Fiona Stapleton, looking at the few studies that we really have in these age groups. Symptoms and signs 5 to 23%, symptoms alone up to 65%. Risk factors, the top of them, digital device use, but also outdoor time, of course that's tied into it, urban living, and ocular allergies and other systematic diseases. Treatment options, well, all we know about is what we currently have. Those are all the papers talk about, and not in a particularly systematic way. And we don't even know that we've got the right diagnostic tests for this group. We just apply them with the normal questionnaires, for example, that we use with adults. So a real challenge in dry eye and the disease that is storing up for the problem. And we know that about 95% of dry eye disease patients are left untreated. So if we look at US data, about 40 million people with dry eye disease. Of those, less than half diagnosed, and less than 1 million, so 1/40th, in terms of treated with a current FDA-approved product. So big numbers to come. So I like to think about it, you've all done your health and safety training in terms of fire. So for a fire to happen, you need 3 factors. You need heat, you need oxygen, and you need fuel. So what's that like in terms of dry eye? Well, here's that angry eye. And there's some really good reports recently published again by TFOS, the TFOS lifestyle report. So these are looking at the impact of lifestyle on the ocular surface. So things like cosmetics, in terms of our environment, lifestyle in general, contact lens wear, elective surgery and medication, in terms of social factors, and in terms of nutrition. And all of those have this massive effect on the ocular surface. Why? Because our tear film is 1/10 of the thickness of a human hair, really finely balanced. Anything that disrupts it, and of course our changing lifestyle in particular, is then going to cause ocular surface disease and the symptoms from that with dry eye disease. But the one that I think is really pushing us over the edge at the moment, and I would say this because this is the report that I chaired, is on the digital environment. So on top of the changes, pollution, allergy, all of these things that we're doing, actually digital devices are just really pushing us. We're not blinking, partially blinking at best, and so the eye is reacting to that. And this was from a systematic review that we did as part of that study, and it identified that there is one thing where most of the evidence points it to be effective, and that's omega-3. There are lots of things in that probable area, and a few things now that we can disprove. So much more research needs to be done. We need far better products to help in these areas. So that significant prevalence of digital eye strain estimated to be around 70%, up to 97% in some study populations. So this huge problem that we're sort of sitting on in terms of our future of our ocular surface and eyes. So actually we want to use digital devices, as Amida's already told us, but the problem is actually that impacts our eyes and stops us using those devices. So there's a real sort of circular problem there that we have to deal with. But of course, it's not just the dry eye, the symptoms that we hear about in terms of meibomian gland disease. So studies looking at Caucasians and Africans, around 20%. But if you look at Hispanics and Arabs, you're looking at about 70%. So huge amounts of meibomian gland disease, which may have led to symptoms already, but may not have. And of course, some of the things that we do, we're all getting older, we'll all eventually need cataract surgery. 55% of people who report for cataract surgery have dry eye disease. And if you look at their ocular surface, that's up to 90%. So a huge number of people then we're going to do surgery on, incisions, cut nerves, we're going to prop their eyes open, we're going to put a bright light on their eyes. So it's not surprising that lots of people then have dry eye afterwards. So if we look at the revised definition of dry eye, and again, this is being worked on now with TFOS JUICE 3, dry eye is a multifactorial disease. There is not going to be a magic bullet that solves it all. We will have to really target what we do. And out to industry, this is what I would say, quite often as a clinician, you get a new product given to you and you say, well, what's it for? It's for dry eye disease. Okay? Which of my many patients, all my patients with dry eye disease, oh, wait, it's for dry eye disease. It will just work. It won't. Unless I target that, unless I think about how that's going to work with other therapies that those patients are on, it's not going to work. It will fail. So it's really important that we get down, we really target who's this going to work for so we can make that benefit. And then on top of that, of course, we need clinicians managing dry eye disease. So this has been released much more recently. This is from the World Council of Optometry, where we've worked with them to try and really simplify down the management of dry eye disease. Because, of course, it's not just ophthalmologists or optometrists who are managing this. It is people like your general practitioner and your pharmacist who are getting patients turning up, talking about their symptoms and wanting a way forward. So it's really important that they understand the basics as well. And so there are things that everybody can do. That's in the outer ring, and then things that eye care specialists can do in the silver ring, and then sort of more specialist things. And in that more specialist things, I've highlighted prophylaxis. So when you go to the dentist, you don't expect that you go once every couple of years and they're just going to clean your teeth and it will be fine. You're told and you tell your children to brush their teeth and maybe even to floss or use mouthwash. Well, actually, it's going to have to be far more like that in our current world with our eyes. Regular use of treatments to make sure that we stay healthy in amongst those visits. So a really different pattern of eye care. But it's really confusing for the patients. I'm sure you'll all smile when you see this slide. That was taken in a pharmacist. I'm based in New Zealand in the moment, and that was just taken from a pharmacist's shelf. How confusing is that to a patient where they're just told, oh, as Ruth said, oh, it's a mild thing, just go and pick yourself up a drop. And yet, these are all for dry eye. And yet, they deal with very little in terms of the breadth of the disease. And even if you can pick a product that may be suitable for you, then you've got to get it into the eye. Don't know whether you've then tried drops yourself. It's horrible. Try and sort of aim them into your eye, get that squeeze, the right amount of pressure, get a bottle that you can actually squeeze to get that pressure into the eyes. So there's some real challenges there in terms of just of our management of these products, and that's almost just as important as what is in the bottle, actually getting it onto the right place on the ocular surface in the form that we want. So beyond the research that I do, we also then want to get out to the patients. And so we've set up a dry eye society. There's one in the US. There wasn't one in the UK, so we've set that up now. And in fact, what I've been doing in New Zealand is setting up the same in New Zealand as well. And I said I would bring this back to Ruth and Sarah because actually they are the leads in the UK with Ruth and Sarah. So patients driving a society, that networking, so they can help each other to better navigate this space. Share stories about actually how long it's taken for them to be treated, how practitioners have struggled to find the right pharmaceuticals for them, and just the issues with polypharmacy and other aspects of their lives as well. So really important that they have that information there. So this is now a live website, and in fact, while we've set it up in the UK and New Zealand, we're getting lots of people. I had one, I think, from Morocco this morning, joining up to that website because there's such a desperate need. And the other thing we've done is we've created an app. So this is an app, My Dry Eye, all one word, that they can use to monitor their symptoms, to put in the medications that they've been prescribed, set themselves reminders. I find it difficult myself to remember whether I've taken medication in the morning. Actually, through this, you can do that. You can put a label on the bottle and they can literally tap it against their phone and it will register that they've taken it. So for me as the physician, they can show me how compliant they've managed to be, because if they can't be compliant with something, it's not their fault. Actually, it's just the wrong thing for them. So it's really important that we collect that data, and this actually gives us that anonymized data so we see what's happening in the real world. So actually, how are they really using these medications that we've told them to use this drop 4 times a day, and actually they're just not coping with that. So how do we build that to better help them through that in the future? So if we think about medications, you're very fortunate in the US that actually you've got a whole load of medications that have come online. A long time from the original cyclosporin to now sort of 2016 onwards, there's been pretty much one product every year, a few gaps in that. So new formulations of cyclosporin, these neuronasal stimulators, either mechanical or later in terms of a nasal spray. We've got drops, so soft steroids, again to help with the inflammatory elements of dry eye. You've got products now specifically targeted for evaporative dry eye, and that's a large part of the dry eye that we see. But again, I think, and you'll see in TFOS Q3, we're going to narrow that down even more to make real special subclassifications, so drugs can be much more targeted to that. And then newer formulations of cyclosporin, faster acting, because again, patients want that really quick action, making a difference in terms of what they do. So let's look back at patients. And in terms of patients, we don't have a lot of data, and this isn't as new as I would like it to be. But this suggests this large screening from this study. So this was the Women's Health Study, so a large population-based study. 1 in 3 patients not satisfied with overall treatment of dry eye, ability to relieve symptoms, length of symptom relief provided, ease of planning treatment use, convenience of treatment use, and side effects of treatment. And if you look down, none of those are really hitting the mark. Now, we have moved on, and there are a few more products since this was published, but I would say that it's not changed hugely. There are still many, many patients out there who are struggling with that sort of day-to-day, how do I get this in the form that I need it? And dry eye is not simple. It is cyclic. You will see when patients fill in proper diaries that actually it changes at different times of year. Their need change. The environment very much dictates that. So at different stages of their life, different treatments will be needed. And it is a responsibility of the people in this room, the leaders in this space, to really give those products, the things that are going to work, and the training for clinicians so they know how to use these that will make the difference for the future. So in terms of my last slide, then I thought it was really important that we focus on actually those unmet needs. And they persist despite the availability of these new treatments. Because it's not just about having a treatment that works in a trial, it's about having a treatment that's really going to work out in the real world. And unfortunately, many patients, despite a treatment being very effective initially, will discontinue. And that might be because actually they didn't get the effect as soon as they want it. Maybe it's just an issue about it fitting with their lifestyle. There are lots of different reasons why treatments then don't continue. But we can clearly see from the data, this is from some recent market reports, that we're not getting that continuation of use. And this is a chronic disease. And that's why it has such an impact on patients, because you can't say, I've got the magic bullet. I can't say this is only going to last a period of time before we get it right and all your symptoms are going to go away. This is something you're going to have to manage over your lifetime. This is why I have suicidal patients turn up in my office. You know, it's that serious for people. So we have a great job to do. It is exciting. This is a fantastic day to see so many of you here with a focus on this disease. It is not a disease that we casually create by giving people glaucoma medication and send them on their way. This is not a disease that will be managed or self-managed by them going down to a local pharmacy. I can say this because my brother's a pharmacist, and they will point you in the direction of the optimum treatment. It is a disease that will only be properly managed when we all put our efforts and brain power into finding the best solution for our patients. So thank you so much for your attention, and we shall move on now to a panel discussion.